All, ladies and gentlemen, thank you very much for this kind invitation for presenting our results on estetrol and estrogen that can be used through life. And we will specifically focus on the cardiovascular impact and the risk of VTE with this new estrogen component. I'm Professor Jonathan Douxfils. I'm the Director of the Clinical Pharmacology and Toxicology Research Unit at the University of Namur in Belgium, and I'm also the Scientific Director of Qualiblet, a contract research organization in Belgium. So these are my disclosure. So we are here to discuss about thrombosis, and thrombosis, you know, is a multifactorial disease. There is a lot of things that can increase the risk of thrombosis, especially, obviously, here we will discuss that. So taking the pill can increase the risk from 2 to 8-fold, but there is also other factors that can increase the risk of VTE. For example, age, being pregnant, obesity, taking a plane, being ill. Abusive genetic factors are also an increased risk of VTE, especially when we are discussing deficiency in certain coagulation protein, and also being severely ill, so being at rest can also increase the risk of VTE by 10-fold. But today we will focus on the risk of VTE associated with combined hormonal contraceptive. So we know that the risk of VTE will increase with the dose of the estrogen component, and especially with 18-year estradiol. On the other hand, the risk will decrease for the same dose of 18-year estradiol. The risk will decrease if you increase the androgenicity of the associated progestin. At the level of several regulatory bodies, and I'm taking here a picture from the European Medicine Agency, there was a lot of debate and discussion regarding the risk of VTE associated with this component. And in 2013, the European Medicine Agency decided to trigger a specific referral in order to assess the benefits of combined hormonal contraceptive. And they clearly conclude that the risk continue to outweigh that the benefit continue to outweigh the risk. So the CHMP endorsed the Pharmacovigilance Risk Assessment Committee recommendation. In this report, there is a very interesting table, and in this table, what we can see it is that you have a kind of I would say classification regarding the risk of VTE. And for women not using a combined hormonal contraceptive, they are referring to an incidence of 2 per 10,000 women here. And then they discuss about different progestin: levonorgestrel, noreltesterone, etonogestrel, norelgestromin, drospirenone, gestodine, desogestrel, cromalinone, dionogest, and normegestrel acetate, for which at that time there was no sufficient information. And interestingly, they report these different incidents, but they forget to mention the more important thing. It is that all these data were gathered in a world in which we only have 18-estradiol as an associated estrogen. So if we are referring to to the history of contraception, interestingly, we can see that starting from 1960, with the first approval of Enovit, an association of mestranol with noretinodrel, we had to wait more than 14 years in order to see the marketing authorization of Clara. And Clara is the first combined oral contraceptive using natural estrogen as an estrogen component. Approximately 10 years later, there was the marketing authorization of Zoeli, which was an association of estradiol with Nomac. Interestingly, in the scientific literature, there was already some ideas regarding the expected risk of VTE with these natural estrogen. And in 2011, in a publication in Journal of Thrombosis and Hemostasis, they report that based on the lower impact of estradiol and estradiol valerate on the hepatic system and subsequently on hemostatic parameters compared to ethinyl estradiol, it can be assumed that estradiol and estradiol valerate are associated with a similar or even a lower risk of cardiovascular event, including VTE and ATE. So this is interesting that already based on biological data, they demonstrate, or at least they had the idea, that estradiol can be associated with a similar or even a lower risk than ethinyl estradiol containing pills, and especially EE associated with levonorgestrel. Due to the European Medicine Agency referral, there was an obligation for the marketing authorization holder to trigger very large epidemiological studies. And this is exactly what was done with estradiol associated with dianojet and estradiol associated with normegestrol acetate with the INA-score and the PRO-E2 study. And interestingly, the idea of this of these large epidemiological study was to assess whether ethinyl estradiol in association with levonorgestrel and these natural estrogen shared a similar risk of VTE. And my question today is ethinyl estradiol levonorgestrel still the safest combined oral contraceptive? We did perform, and it is currently submitted in Frontiers in Endocrinology, we did perform a meta-analysis of all studies comparing natural estrogen with ethinyl estradiol containing pills. And not surprisingly, we observe a 33% reduction of the risk of VTE when we compare natural versus synthetic estrogen. So it means that natural estrogen are statistically associated with a 33% reduction of the risk of VTE compared to ethinyl estradiol containing pills. Importantly, due to the heterogeneity of these studies, we were not able to use the adjusted odds ratio of each of these studies. So it means that these data are even not adjusted for possible confounding factors. And we know that natural estrogen are often used in a population which is more unrisked than synthetic estrogen. Interestingly, what we decided then to do is to focus on studies for which we have the possibility to adjust for the confounding factors. And interestingly, the only one that for which we were able to do that were the studies from the Z group, so the study, the PRO-E2 and the INA-score studies. And interestingly, by using the adjusted hazard ratio and putting it into a meta-analysis, we were able to demonstrate that based on these two studies, we have a statistically significant reduction of the risk of VTE by 49%. And this is really, really interesting because not only it confirms the result that we obtained with the crude odds ratio that I showed to you the slide before, but it is also very reassuring because these studies were requested by the European Medicine Agency, and so they clearly demonstrate that natural estrogen are safer than synthetic one. As we are discussing the risk of VTE, ethinyl estradiol in association with levonorgestrel is no longer the safest combined oral contraceptive. The safest combined oral contraceptive are natural estrogen. So we know also that for the development of a combined oral contraceptive, there is a list of recommended hemostatic investigations that need to be done during the development of steroid contraceptive. And especially, the European Medicine Agency recommends to assess several coagulation factors like antithrombin, APC resistance, D-dimer, factor 2, factor 7, 8, protein C, protein H, prothrombin fragment 1, 2. And a new hemostatic factor, SHBG. So I'm not sure this is really an hemostatic factor, but they recommend it to assess SHBG as well. We know that with combined oral contraceptive, we will have an increase or a decrease of all of these coagulation factors. And it is really difficult, even for an expert in hemostasis, to assess what will be the impact of all these small increase and decrease in the coagulation factors. So this is why we will focus on APC resistance measured using the endogenous thrombin potential. So ETP stands for endogenous thrombin potential. So we will measure with this test, this is a global coagulation test, and we will measure the endogenous thrombin potential in presence and in absence of activated protein C, and we will see how we can do that. This is a short reminder of what is, at the end, the coagulation cascade. It is a simplified view of the coagulation cascade, and an important effector of this coagulation cascade is obviously thrombin. So thrombin here is really the key effector of the coagulation cascade. Thrombin is able to cleave fibrinogen in order to form the fibrin clots. But obviously and interestingly, thrombin is also able to regulate its own production by activating the protein C protein S system. And this is exactly what we can see here. So thrombin is able to activate protein C in order to form activated protein C, which will form a complex with protein S, and the complex of activated protein C and protein S will then inactivate activated factor VIII and activated factor V, meaning that at the end, this will then regulate the activation of prothrombin to form thrombin. So this is really, really interesting, and this is why we will focus on thrombin in order to assess all the changes that can occur when we are taking the pill, so when ladies are taking the pill. Because pills are associated with a decrease in antithrombotic factors, like, for example, protein S, TFPI, antithrombin, but they are also associated with an increase in procoagulant factors, like factor 7, factor 9, factor 8, factor 10, even sometimes factor 5, and also prothrombin. So this is interesting to see that at the end, taking the pill is shifting the ladies to a prothrombotic state. In fact, when a lady is taking the pill, there is a decrease in the level of protein S, and this decrease in the level of protein S, but also the decrease in TFPI, which is also tightly regulated, whose reaction is tightly regulated by protein S as well, will at the end lead to a state which is named APC resistance. And in order to assess this global APC resistance, which is a risk factor for VTE, we will need to use the recommended biomarker by the European Medicine Agency, which is the ETP-based APC resistance assay. So how can we assess this ATP-based APC resistance? We will measure the generation of thrombin over time. And this is really, really interesting to see how we can do that. In the first part of the curve, we will add a triggering reagent. The idea of this triggering reagent is to permit the generation of thrombin. So we are able, over time, to assess in the test tubule what is the concentration of thrombin. And obviously, at the very beginning, thrombin increased, and then it decreased due to the presence of anticoagulant factors. On the other hand, and this is the novelty with this test, we will add a certain amount of activated protein C just to assess whether there is a resistance or not towards this edit activated protein C. So we will have two conditions in this test, one condition in absence of APC and the second condition in presence of APC. Obviously, when we are putting APC into the test-cupule, we will see a decrease. We will see a decrease of the area under the curve. So we are reducing the total amount of thrombin generated. It's normal because we are putting an excess of an anticoagulant factor. The amount of activated protein C that we are introducing in this test is able to reduce by 90% the area under the curve. And this is quite important because this 90% reduction in the area under the curve will permit to design a ratio, to calculate a ratio, and this ratio will be around 0.1, meaning that if you are normalizing these results with the results of a patient, for example, you are providing a scale from 0 to 10. So 0 meaning that you have no APC resistance at all. So it means that when you are putting APC here, there is no thrombin generated at all. And you can have a complete resistance towards APC, meaning that when you put APC, you are not able to see any difference between these two curves. So this is an important part because we will be able to detect any APC resistance by seeing the increase in this second thrombin generation curve. And this is exactly what you have here. For example, here it is a lady taking ethinylestradiol in association with gestodine. And as expected, we are observing an increase. We are observing an increase in the conditions in absence of APC. Please remind that combined hormonal contraceptives are able to increase several procoagulant factors. So it means that by increasing these procoagulant factors, you are able to increase the total amount of thrombin generated even in absence of APC. But this is not the only observation that we have here. Obviously, we are observing an increase in procoagulant factors, but we are also observing a resistance towards activated protein C. So the amount of APC that we are introducing in the test are no longer able to reduce by 90% the area under the curve of the first curve. So it means that here, for example, we have an APCSR, so normalized activated protein C sensitivity ratio of 4.1. And this is really, really important because it means that when taking a combined oral contraceptive with ethinylestradiol, you are both introducing a procoagulant state by increasing the coagulation factors involved in the procoagulant phase of the coagulation cascade, but you are also introducing a resistance towards activated protein C by reducing the level of anticoagulant factors. We were not the only and the first study group, research group to demonstrate that activated protein C resistance as measured by the endogenous thrombin potential, and it is really, really important to use this method, can be associated with an increased risk of venous thrombosis, and also that it can be used to predict the risk of VTE. Interestingly, we decided to design a graph in which we will assess the NAPCSR of several combined oral contraceptive. This will be reported on the x-axis, and on the y-axis we will report the risk of VTE extracted from Cochrane literature review from Maria de Bastos. And interestingly, we plot these NAPCSR with the risk of VTE. And so here, for example, for a lady not taking the pill, we have a mean NAPCSR of 1.46, and obviously the risk of VTE is 1. This is the reference. So this is the thrombin generation curves in absence and in presence of activated protein C that you are normally observing in a young lady not taking any combined oral contraceptive and not suffering from coagulation abnormalities. This is a curve that we obtain with 18 estradiol at the dose of 20 microgram with levonorgestrel at the dose of 100 microgram. So the NAPCSI is higher. So the mean NAPCSI in this population is 3.53. And the estimated risk of VTE coming from the Cochrane literature review was 2.2. Interestingly, you can see that you have an increase in the procoagulant factors, and you have also this resistance toward activated protein C. And we did perform exactly the same experiment with 18 estradiol 30 with levonorgestrel 150. We observed a similar mean NAPCSR, and also coming from the literature review, the risk of VTE was also very similar, so 2.40. We did the same with 18 estradiol 20 with desogestrel 150. The mean NAPCSR was 4.35, and the risk of VTE coming from the literature was 3.40. With 18 estradiol 30 and desogestrel 150, we obtained a mean NAPCSR of 5.41, and the thrombotic risk coming from the literature was 4.30. Interestingly, here you can really see that you have a high increase in the amount of thrombin generated with the procoagulant factors, and you have a very important resistance towards activated protein C, which is even higher than the normal curve in a normal population. And then we perform the same with 18 estradiol 35 with cyproterone acetate 2. The mean NAPCSR was 5.1, and the thrombotic risk from the literature was 3.90. This was the first graph, the first iteration that we performed for this correlation. Obviously, now we have included more than 350 ladies into this model, and the model is now looking like this. So we have a kind of exponential increase with the increase of NAPCSR, meaning that the higher the NAPCSR, the higher the risk of VTE with this combined oral contraceptive. The question arises to know whether this model is capable of correctly predicting the risk of thrombosis associated with a pill in particular. And to do that, we did use an external validation to demonstrate the robustness of this model. We planned to assess the estimated risk of VTE with an association of 18 estradiol at 30 microgram with Dienogest. As the results from this study were only available in 2020, it was not able to include this into the Cochrane literature review. So this is a very good choice in order to assess, to perform an external validation of our model. And it shows, interestingly, we obtained, with 18 estradiol 30 Dienogest 2, we obtained a mean NAPCSR of 4.79. So the estimated thrombotic risk coming from the model, so here we plot the NAPCSR at 4.79, and we obtain an estimated thrombotic risk of 3.6. We did the same with another study coming from the literature and which was published in 2021. It is the PRO-E2 study with estradiol in association with NOMAC. And interestingly, here we obtain a lower value for the mean NAPCSR. So we obtain a mean NAPCSR of 2.57. So based on our model, the estimated thrombotic risk was 1.7. And this is really, really interesting because for this external validation, we were able to retrieve an expected risk of VTE, which was very close to the observed risk of VTE coming from the literature, and we will see that into further detail in the next slide. Here is also another slide to demonstrate the robustness of the model. So here you have the expected relative risk coming from the model, and this is the observed relative risk coming from the model. And you can see that we have an R-square of 0.98, which is very, very high, and that all the expected risk of VTE are very close to the line of perfect association. So it means that the model is really, really able to predict the risk of VTE of a particular combined oral contraceptive. And this is what we planned to do with E4-DRSP, because obviously with E4-DRSP up to now, we don't have access to any large epidemiological study. It will take more than 7 years to get these results. And if the product is safer than the other one, we cannot wait to use it. We cannot wait 7 years before getting these results to be sure that that E4-DRSP is safe. So it is really, really important to be able to characterize the risk of VTE before the results of these large epidemiological studies. And this is exactly what we decided to do by measuring the NAPCSR in ladies taking E4 in association with DRSP. And we obtained a mean NAPCSR of 2.30, which is very, very low. It is the lower NAPCSR obtained with combined oral contraceptive. And the estimated thrombotic risk was 1.5, so compared to non-user, which is also the lower risk observed based on this model. If we compare the different NAPCSR obtained after the validation of the model, so in order to assess the robustness, we used 18-estradiol in association with Dienogest, we used E2 in association with NOMAC, and what we were able to see, it is that we have a very good match between the thrombotic risk, which is estimated from the model. So for EE Dienogest, it was 3.6, and the thrombotic risk from the literature was 3.4. For E2 NOMAC, it was 1.7 for the model and 1.6 for the thrombotic risk coming from the literature. And for E4-DRSP, the mean NAPCSR is very low, 2.30, with a thrombotic risk from the model of 1.5. Obviously, we don't have yet any thrombotic risk from the literature because we don't have access yet to this large epidemiological study, but this is really in line with the clinical data showing a low impact on coagulation, and we will see what is the incidence estimated from the clinical data and from the model for E4-DRSP, and you will see that it also matches very well. So it's really, really interesting because these results are providing very important information on the potential risk of thrombosis. Just to really demonstrate what is the difference between E4-DRSP and the safest combined oral contraceptive as considered by national and international expert societies. This is the thrombin generation curve for EE in association with levonorgestrel. You can see here the high increase in procoagulant factors and the huge resistance towards activated protein C. This is totally different from what we obtained with E4-DRSP. With E4-DRSP, we have a very low increase in procoagulant factors. Obviously, there is an estrogen, so it is expected to have a slight increase in procoagulant factors. But look at this activated protein C resistance. There is no clinically significant difference compared to not using any combined oral contraceptive. It means that the APC resistance is really in the same range as the one observed in ladies not taking combined oral contraceptive. Interestingly, we were also involved in the development of E4 alone for the relief of menopausal symptoms, and we obtained very similar results, to what we were able to assess with E4 in association with DRSP. Interestingly, if you are looking in contraception, here you have a 30% increase in the relative change from baseline for the risk of activated protein C resistance, which is in total contrast with 18-estradiol containing pill, for which we have more than 150% increase in the resistance towards activated protein C. And if we are looking at menopause, you can see that E4 it is here, E4 demonstrate a 42% increase relative increase in APC resistance compared to baseline, while with estradiol containing pills, not really pills, but estradiol hormonal replacement therapy, taking orally, we have approximately a 100% increase. In fact, E4 at the dose of 50 milligram is really similar to transdermal E2 at the dose of 50 microgram. So we can say that E4 at the dose of 15 milligram is really similar to transdermal E2 with regard to the risk of VTE in the menopausal population. And this is really the first estrogen which is similar to transdermal E2 in the world of menopausal replacement therapy. And this is really also in line with what we observe for E4 in association with DRSP. So meaning that here we have a product at the dose of 15 milligram, which has a very low impact on hemostasis and on activated protein C resistance. We also compare the effect of E4 DRSP on other hemostatic factors, obviously, taken individually, and we compare it with drospirenone alone, just to see whether there is a difference between drospirenone at the dose of 4 milligram and an association of estetrol at the dose of 15 milligram and drospirenone 3 milligram. And interestingly, you have to know that DRSP as a progestin-only contraceptive at the dose of 4 milligram has not been categorized by the regulatory bodies as having a different risk of VTE from other progestin-only contraceptive. And hemostatic investigation of individual coagulation factors did not reveal a clinically relevant impact of this DRSP at the dose of 4 milligram. So here you can see that DRSP alone or in association with estetrol really have the same effect, and which is in sharp contrast with an association of 18-estradiol with drospirenone. So when you are putting drospirenone with estetrol, you are able to observe a similar impact on hemostasis than DRSP alone. But when you put DRSP in association with 18-estradiol, you have a totally different impact on hemostatic factors. Either it is on factor 7, on factor 8, on protein C activity, or on antithrombin. And this is really important because this is also something that we observe for E4 DRSP. Please go back into my slides and you will see that the increase for E4 in association with DRSP at the dose of 20 microgram of 18-estradiol show an increase in the NAPCSR above 200%, while it is only 30% for E4 in association with DRSP. So really this is the estrogen that drives the risk of VTE. And here, E4 in combination with DRSP has a coagulation profile which is similar to DRSP alone, whereas we have a clear difference when DRSP is used in association with estradiol. This is another slide to demonstrate that E4 DRSP is very close to what we have with desogestrel alone. So this is ladies not taking combined oral contraceptive. We know that desogestrel has no impact on the risk of VTE, desogestrel at the dose of 75 microgram. And here is E4 DRSP. So practically no impact as well. So the black line here is the upper limit of the normal range. And you can see that an association of 18-estradiol with levonorgestrel clearly outweighed, it is above the upper limit of the normal range. The mean thrombin generation curve is above the upper limit of the normal range. This is not the case with E4D-RSP. So clearly with E4D-RSP, we have a low impact on hemostatic factors. So now that we have discussed this biological data, I think it's also interesting to look at the clinical experience that we have with E4 in association with DRSP. And data from phase 3 studies support the assumption that we observed with biological data. We only had one single VTE event over 3,417 participants in the US, Canada, and European recent studies. This represents an incidence of 3.7 per 10,000 women year. And interestingly, if we are looking at the NAP-CSR model, and if we translate the risk into an incidence, we have an incidence of 3.8 per 10,000 women years. So meaning again that there is a match between the clinical data and the model, proving the robustness of this model. In comparison, we observed a higher number of VT events in all studies that were performed these last years with 18-estradiol containing combined hormonal contraceptive, because here we not only have combined oral contraceptive, but we also have a vaginal ring and a patch. So now that E4D-RSP is on the market since more than a year, there was interesting data that can be extracted from some pharmacovigilance database, and this is exactly what we did at the European level using the Drovelis database. Here, in this experiment, we systematically evaluate the frequency of adverse events associated with a specific hormone combination used in contraception, and we use a specific statistical method which is called the disproportionality reporting ratio. Interestingly, the idea of this disproportional reporting ratio is to analyze whether there is more VTE events report over the total number of events report with a specific combined hormonal contraceptive. So we put the threshold at 1 for EE-LNG, which is the reference, and we check whether there is a disproportional reporting of VTE event with several combined oral contraceptives. And what we were able to demonstrate, it is that there is obviously no signal at all for an increased risk of VTE with E4D-RSP. So we are below the expected background rate observed with EE-LNG, which is considered today as the safest combined oral contraceptive. And interestingly, we were able to demonstrate, and this is statistically significant, that natural estrogen are safer than any other combination containing 18-estradiol, that among natural estrogens, the association of E4 with DRSP shows the safest profile, and these results again support the observed effect of our meta-analysis, and they are also in line with the data using the normalized activated protein C sensitivity ratio marker. So this is really, really interesting because now we have biological data, we have clinical data, and we have pharmacovigilance data, which all demonstrate that E4D-RSP has a lower risk of VTE compared to EE in association with levonorgestrel. So the conclusion from the biological, the clinical, and the real-life experience with E4 are up to date very reassuring.
These hemostatic biological data using a global coagulation test like the normalized activated protein C sensitivity ratio, the current clinical evidence coming from the phase 2 and phase 3 studies, and the life experience using the data coming from the pharmacovigilance database are all very reassuring, and they are all pushing into the same direction. That E4, ERSP, and also natural estrogen in general are clearly safer than synthetic estrogen, even if ethinylestradiol is associated with levonorgestrel as well. So E4 is one of the safest compounds in contraception, and the data that we will be able to gather coming from the large epidemiological study, so for example from the INAS-NACE, which is a post-authorization safety study requested by the European Medicine Agency, will only be there to further confirm the observation that we are currently analyzing today, but they will not be able to characterize the risk, which is already characterized using the data from the biological, the clinical, and the real-life experience. Regarding epidemiological studies, it's also quite important to understand that these large epidemiological studies like the INASCO, for example, will take more than 7 years to be issued. And these epidemiological studies are requested due to regulatory standards and legal obligations following the risk that has been observed with ethinylestradiol containing pills. So these requirements are there due to the risk observed with ethinylestradiol. And now that we have access to data with natural estrogen, it means that these data are still requested, but we have other ways to identify the risk. And this is exactly also what we did with our biomarker investigation and the analysis from the ultravigilance database. And I'm sure that in the coming months we will have a similar analysis coming from the FIS database in the US. I think it is really important. But even if these are even if these data can be of interest in large epidemiological studies, you have to know that thrombosis is a multifactorial disease, and that these non-interventional studies are not always able to capture all these risk factors, and they are not always adjusted for that. And this is exactly what we observe with our meta-analysis comparing natural estrogen versus ethinylestradiol containing pills. So they are providing rough estimates, but they cannot be translated into individual strategies. So that's why we developed this biomarker, which is of particular interest to assess the impact of a particular combined oral contraceptive on hemostasis at the individual level. And interestingly, when we are looking at the data coming from the population, this is linked with the risk of VTE from very large epidemiological studies. So you also have to know that we are currently in discussion with regulatory bodies and especially the European Medicine Agency to make the normalized activated protein C sensitivity ratio recognized as a predictive tool to characterize the risk of VTE with combined oral contraceptive, and it will help to save 7 years because these data are already there, and we are not waiting for data coming from large epidemiological studies that will not have any proof of evidence at all compared to what we already know about the product. So, in a very interesting manner, at the European Society of Contraception, there was an interesting debate regarding natural estrogen, and the question specifically based on should these natural estrogen be the first choice for combined oral contraceptive. And I really think that if we are speaking about safety, natural estrogen, and especially estetrol, because it has also a very particular pharmacodynamic profile, I think it's time to revise these guidelines. It's time to revise the guidelines based on the latest evidence, because we know that the choice of the estrogens matters when considering the risk of VTE, for example, and also the cancer risk. And classification of combined oral contraceptives should be reappraised considering these latest scientific evidence. So in conclusion, the choice of the estrogen matters when considering the risk of VTE, but not only. A simple tool like the NAP-CSR can characterize the impact of a particular combined oral contraceptive on hemostasis, and this is linked with the risk of VTE from very large epidemiological studies. And all the data that we have so far with E4 ERSP, either it is hemostatic data, clinical experience, phase 4 studies, so especially the extraction from the ultravigilance database are not only reassuring, but they characterize the risk of E40 RSP, which is lower than the risk observed with 18 years today or levonorgestrel. And I would think that it is important to make a reclassification of combined oral contraceptive considering the latter scientific evidence. I thank you for your attention, and I'm open to your question.